Support comes from Hampton Roads Community Foundation, partnering with donors from all walks of life to improve southeastern Virginia through grants, scholarships, and leadership initiatives. Learn more at hamptonroadscf.org.
Hello, everyone. I'm Barbara Ham-Lee. High blood pressure, diabetes, obesity, sickle cell anemia, high cholesterol, smoking, not exercising regularly, stress. All of these diseases and conditions disproportionately affect the Black community, and all are risk factors for stroke. So what is stroke? What are the signs and symptoms? How can you prevent it? And what is F.A.S.T? F.A.S.T. Cardiologist Dr. Keith Newby joins us with some life-saving information that you will not want to miss over this next hour. Another View on Health is next, right after this national, regional, and local news from NPR and WHRO News.
Discussing today's topics from an African-American perspective, this is Another View.
Good afternoon, everyone, and welcome to Another View. I'm Barbara Ham-Lee. We're going to start this hour with celebration. Guess what? Another View received an award from More Laughing. It is called the OG Award, which stands for Original Gigglers. Now, if you are a regular listener of Another View, you know that Allison Moore, who is a clean comedian, was a frequent guest on our roundtable, and she is back in Hampton Roads, so welcome home, Allison, if you're listening. We received a letter from her saying that Another View had been selected as a recipient of the More Laughing OG Award for outstanding support of her career over the years. And one thing I want to read from her letter, she said, "More Laughing OGs have made exceptional contributions and dedications to my rise and journey, which has not gone unnoticed. Being a roundtable pundit on your show for several years adds tremendous value and increases my skill set as an entertainer, and I'm grateful for you giving me the platform and opportunity." Therefore, her team unanimously agreed that we were deserving of an OG More Laughing Original Giggler Award. So, Allison, we thank you so very much for that award and for that recognition, and we wish you well as you continue your pursuit of comedy, and hopefully we'll get you back on the roundtable soon. A couple of other things going on in the community very quickly that are important, particularly if you are a resident of the city of Norfolk. The city is developing its next comprehensive plan. And they're asking the question, how should Norfolk grow across the next 25 years? Now, they are holding a series of listening workshops across the city. One being tonight from 4 to 7 p.m. at the Mary D. Pretlow Anchor Library in Ocean View on Ocean View Avenue. Now, this is a open house style with a drop-in, drop-out format. Just stop by, give them your thoughts, and I know that they will be appreciative. There are several other events going on Monday, December the 4th, December the 6th, 7th, and December the 11th at various locations. So go to norfolk.gov or go to nfk2050.com to find out when the next meetings are and make sure that your voice is heard. And also, the Norfolk Department of Public Health is conducting a community health needs assessment. Now, they do this every 3 to 5 years, and they really want to hear from you about the how things are going in terms of health needs and particularly in terms of mental health. It takes just a couple of minutes to fill out the survey. And if you go to norfolk.gov, you will find the link there. Please make your voice heard so that the Department of Health can plan appropriate programming to help all citizens. So thank you very much for that. And then finally, if you're looking for a really unique place to find some holiday gifts, Heartworks Designs is happening tomorrow. The studio opening celebration is happening on December the 1st from 3 to 9 p.m. at Kate Thomas Art, which is at 1701 Colley Avenue in the city of Norfolk. Now, these are beloved beadwork and embroidery. Hello, can I talk? In support of South African women artists. Dr. Jennifer Fish with Old Dominion's Department of Women and Gender Studies has been very involved with working with women in South Africa who make these jewelry and embroidered pieces and use them to raise money and for sustaining their villages. So please go by. The works are incredibly beautiful, and I think that they will make some unique gifts for you if that's what you're looking for. So here's a question for you. Have you or someone you know had a stroke? Were you able to recognize the symptoms and get immediate help? Why is stroke so prevalent in the Black community? Cardiologist and Market Director of Community Health Improvement and Engagement with Bon Secours, Dr. Keith Newby, is here with some answers. Hello, Dr. Newby.
How are you doing?
I'm doing fine. Okay, what's up with the new title?
I know people out there say, what?
What? What is going on? Market Director of Community Health Improvement and Engagement. You go.
Yep. Yeah, I tell you, I'm always trying to do something. I tell you, I can't sit still for 5 minutes. You know how I am.
Have you been diagnosed with ADHD?
I tell you, it makes you wonder sometimes. What you say earlier? I was sending you emails at what time?
Yes, exactly. 12:03 a.m. I'm like, does this man ever sleep?
I'm trying to make sure I educate our folks out here.
Absolutely.
Well, so what happened was I wanted to make some decisions about where I wanted to take my life and career, and I was afforded the opportunity. Bon Secours approached me about a year ago and said, listen, we like the things you're doing. Wanted to see would you be willing to come work with us. We want to be more engaged in the community, and this would be a good way to potentially look at doing that. So I said, well, the main thing for me is means and opportunity. I said, if you're willing to be supportive of what I need to do, because again, I'm big in the community, trying to make sure we change the outcomes of what we do. And they said they were fully engaged. So I said, okay, I'll give it a shot. So I'm actually merging the practice with Bon Secours. We're actually moving next week. We'll be on the building on 21st Street. So I'll be going there. So part of it, I'm still doing cardiology. So I want to make sure people understand I'm still a cardiologist. I still will be doing my practice, but like what I was doing with Centera, I was doing some of their health equity work. That was kind of in my so-called spare times where I'm up at 12 o'clock doing stuff. I will be doing similar. So it's a hybrid position. So I'll be, of course, still managing patients and doing my practice. And I'm still practicing out of Centera Heart Hospital. So I want everybody to make sure they know I'm not leaving Norfolk. I'm staying in Norfolk.
Gotcha.
I'm just going to be working with them. And, again, for me, how do we make impact in communities, with all the public health work I'm doing now and, things we're talking about today.
Absolutely.
This is a big, important subject, and it really does impact our community. So
and before we jump into stroke, because we really need to spend a lot of time on this, which we're going to do, I have gotten a couple of questions from our listeners wanting to know if you are accepting new patients.
Yes, I am.
Okay.
My office number is still going to be the same, which is 757-624-1785.
Okay.
But I'm going to ask people if they would give us, because I'm doing the moving next week.
Yeah.
So if they could give me, they can reach out, but we'll be really in play and working
right after
fully,
the first of the year?
Right out, yeah. Well, no, actually, you know me. I ain't waiting that long.
It's only a month.
Listen, you know good as well. I know. We are working next week, but I have to go through a process of, this new EMR system and all that. So we're officially starting where we're opening up the practice on December 11th.
Gotcha.
So
Okay.
it's just next week is a kind of a training and getting all acclimated and all that thing.
Okay.
So we'll be full force then. So, but I think it's going to be good for us for a lot of different reasons. It's going to be an epic system. So, the EMR I think it just works better.
Yeah.
And
the EMR
it'll be
is
a lot.
electronic medical records for those who may not be aware. That's right. Now we can't speak in
Using
acronyms.
Yeah, I'm sorry. We're gonna speak some more acronyms in a minute.
Absolutely.
Too, so.
Absolutely. Okay, so let's dive into this. What is a stroke?
Okay, so contrary to what a lot of people think, stroke is a form of heart disease. And a lot of people will say, well, what does that mean? Well, think about it. If you look at the definition of heart disease, and it's a broad diagnosis, and I tell people all the time, that's like if you say the word car. I mean, you got a Mercedes, you got a Tesla, you got a Pinto, you got a Gremlin. I know for y'all, listen, for all you young folks, you won't remember those cars. But there are different cars, just like different forms of heart disease. And anything that affects the heart or the great vessels is a form of heart disease. So when you think about the great vessels, your main aorta that comes out of the heart, that's your big vessel that has side branches that supply blood to the brain, to your muscles, your organ systems, your legs, everything. So anything that affects a vessel that affects an organ is a form of heart disease. So a stroke is when you have an obstruction of blood flow to a part of the brain. Essentially, that's what a stroke is. Now, there are different types of strokes that we could get into as well, but I want to make sure people understand that anything that affects the heart or great vessels is, in fact, a form of heart disease. So that's what a stroke is. So when people have that, that's what we're looking at.
So I read in one, because there are many different, articles and so forth that you can read about stroke, but they described it as a heart attack of the brain. Is that what you described it that way?
Well, I don't. In certain populations, you start saying that term is going to confuse a bunch of people.
Gotcha.
In depth, but by definition, yes.
Okay.
It really is because in a heart attack, you're obstructing a coronary artery. So a vessel that supplies blood to the muscle of the heart is by definition a heart attack. So if you obstruct a vessel supplying blood to the brain, that is, by definition, yes, it is like a heart attack of the brain, but I try to keep those separate just to confuse people.
So there are two different types of stroke?
Yeah, well, the main ones you see is the ischemic and hemorrhagic. Those are kind of like the main ones you see. Ischemic, and some people will say embolic, but embolic is a form of an ischemic stroke. So when people say hemorrhagic stroke, that's when you have a bleed in your skull. So like I say, if a blood vessel burst, like from an aneurysm or whatever, that is a hemorrhagic stroke because you're bleeding into the brain. And ischemic stroke is when you obstruct a blood vessel. So that, of course, when you talk about that kind of stroke, that's like mostly from a clot that flips. So then you can have an ischemic stroke can occur in the brain itself, or it could flip from say example, like people with atrial fibrillation, and we've talked about that before on the show. Atrial fibrillation is a heart rhythm disturbance that, left untreated without blood thinners, can form clots in the heart, and those clots can break off and go
to the brain.
Yeah, exactly. So I just really, I think, just keep life simple. Ischemic and hemorrhagic, I think, are what I would say those are those are like your main two.
So are there different symptoms for each of those types, or is it stroke in terms of the symptoms?
Yeah, actually no, and I tell you why, because it depends on where. The brain is an interesting mystery. The reason why I love heart so much, heart is like, we've figured out a lot of stuff with heart. There's still some nuances of things that we're still working through because a lot of things in heart that people don't understand is how you convey what you feel, and we had this debate with patients before, because if they come to the office and you ask them, how you doing? I'm fine. And then I had this with a lot of guys who would come in and say they're fine. They I'm not feeling anything. And then the wife comes in the next time fussing at them because they say, you're not fine. You were complaining about you can't half breathe. And I'm like, well, if you don't say anything, I can't know anything.
Right.
So
Right.
when you talk about symptoms, that impacts how it's perceived. Like what my job is to try to figure out what's going on with you. So I need as much information as I can get to try to understand what you feel, but what people experience. So in other words, I could put say chest pain. I could put chest pain in you. You may say I'm feeling something, and you may describe something. You could put that same chest pain you're feeling in me. I may say something different because it's about my perception of what I'm feeling, and that conveys a difference in terms of how you convey it to your doctor. So when you talk about symptoms of a stroke, you have to be able to say, okay, this is what I have experienced, or have somebody do that for you, because depending on where the clot went or depending on what part of the brain was affected impacts what those symptoms are. And hence that thing when you hear that term, like, I think we I don't know if you mentioned it, but the acronym, there's
FAST.
two acronyms, there's FAST and then B-FAST.
And B.F.A.S.T.
When they
right.
say, so when they say FAST, facial drooping, if your face droops on one side, and when you have that person speak, and you could tell there's something wrong, they're not speaking as clearly as they once did, or the face droops on one side, that is one part of the brain that's affected by a specific artery to a specific part of the brain. Weakness on one side versus the other. If somebody just all of a sudden wakes up, or they're working during the day, all of a sudden their arm gets numb and weak. Now, we've all experienced some things like that. I don't want to put people in panic mode because, something happens. You may get numbness in your arm for a minute. It doesn't mean you're having a stroke. You have to look at the entire picture. But if your arm gets weak and it's persistent, you don't want to, wait 3 weeks before you decide to come in and have somebody check that out. If there's weakness, if there's like balance problems or blurred vision or change in vision, things that are different from what you experienced before, those are things you need to be able to recognize quickly and act upon. Because just like that heart attack we talked about, every time is function. So in other words, if you wait too long when you're having symptoms of a stroke and don't get treated, that damage could be permanent, versus if you get there early enough, just like with heart attacks, we get people in the hospital early enough, we open up those vessels, and it could be through either stenting, balloon angioplasty, or with medications, where with brain stuff you could do, sometimes it's the same thing. We give sometimes clot-busting medications if we get to people early enough and we know it's not a hemorrhagic stroke. You don't want to give blood thinners to somebody's bleeding up there already. But if you catch them early enough, you can make an impact and reverse it a lot of times. But the key thing is the recognition.
So you don't need all of them necessarily, right? The face drooping, the arm weakness, the speech difficulty. But if your gut is telling you too that there's something wrong, you need to go straight to the emergency room. Now, all the materials that I read there was saying that time really is of the essence, as you just said, because you want to get it treated as quickly as possible to minimize the results or the damages that could be done. Right?
Because if you look at the incident, like we talked about those two strokes, ischemic versus hemorrhagic. So if you look at the kind of the percentage of each one, if you take 100 people coming with a stroke, approximately 80 of that 100, they're going to be ischemic strokes, and 20 are going to be hemorrhagic or bleeding. So the advantage is, if it's ischemic and you can open up that vessel, you can save brain tissue. So the statistics are on the side that you could get something that could help reverse it. And that's what you have to do, is recognize that time factor. If you can get to the hospital, really, we want you there within an hour, 2 hours tops. But you have about 4 hours to give these clot-busting drugs. But after that, you don't, because the potential, because you could take an ischemic stroke and turn it into a hemorrhagic stroke if you wait too long. Because what happens, the blood vessel that's obstructing blood flow to that brain, you get damage after that, after where that vessel was occluded. And when you start giving a clot-busting drug or blood thinners, too long after the stroke occurred, the damage that occurred can cause the vessel to rupture and open, and then I could take an ischemic stroke and turn it into a hemorrhagic stroke by waiting too long. So that's why I tell people, you get there quickly, you have the highest potential to reverse it.
757-440-2665 or 1-800-940-2240 are the numbers to call to join our conversation. Have you or someone you know, a loved one perhaps, had a stroke? Tell us your experience. How quickly did you get to the hospital? Were you able to reverse the effects of that stroke? 757-440-2665 or 1-800-940-2240. So, Keith, why are African Americans so prone to stroke? I mean, I've read a whole list of things that we always, whenever we, at least, and I laugh all the time, although it's not funny, but it's like, when everybody else gets a cold, we get pneumonia. And here again is another example of that. What are we doing that is causing us to be able to be more prone to stroke?
Well, if I could be so bold and honest, our lifestyle absolutely sucks. I mean, we have, our population is the worst at seeking medical attention, adhering to medical attention, following instructions, and doing what we're supposed to do. As example, you look at what are the medical conditions that put you at risk for stroke? Hypertension, that's not controlled well. Diabetes does not control well. High cholesterol levels that are not controlled well. Like being overweight or obese, because that tends to lead to those things we just talked about. If you smoke, you are at high risk for stroke. So when you talk about, and I think I may have mentioned this in one of our prior shows, but if you look at our potential way we handle things, you talk about asymptomatic diseases. Hypertension is typically an asymptomatic disease process. I wish I could find a way to make hypertension make you feel bad all the time.
Right, because you don't really think about it because you don't feel anything.
Yeah, exactly. Yeah. So you run into this issue where you have these processes, and there are other factors involved too. We'll talk about that in a minute. But if you have an asymptomatic illness and you tell somebody, I need you to take this medicine, I need you to change this lifestyle, it's hard to get people to do that. I mean, and I understand why. It's just when you think about it, you asking somebody to take a medicine who says, I generally feel fine, but you got to change this part. There's something about medicine, that it's like this evil word for a lot of people in our community. And I understand a lot of it's trust factors and, other things that, you think somebody's always trying to make money off of you. And I get that part. But, the thing is, when you look at data, like, somebody would tell me, I don't need to take this medicine. I've taken all these vitamins. I'm like, well, what are vitamins supposed to do? I said, how's that going to lower your blood pressure? Or they do these beats and other things, which I say, hey, go for it. I mean, far be it for me to tell you different. I say, but understand, my role is to walk you through this process of good health. So I'm supposed to be your tour guide, so to speak. So I'm going to look at everything and try to guide you based on what the data in the literature says. I mean, because I tell them, I said, listen, I haven't seen any randomized controlled data about eating beets lowering your blood pressure. I say, I'm not saying you can do it if you want to. I'm not going to tell you not doing it, but I can't like advocate it for wholeheartedly because I haven't seen randomized data that says this works.
This works.
A lot of people anecdotally says it works, and I say go for it, but I gotta do the things that I know have been proven to work.
We tend to want to believe the commercials as opposed to believing the doctor.
Yeah, I mean, and I get it. I get it. If your doctor doesn't talk to you much, or he doesn't really convey information to you well, if you don't feel like you feel fully educated when you leave, that they've given you the tools you need to understand why he's asking you to do these things, I get it. That part I do understand. That's why I take the approach I do. I try my best to educate people to say why I'm saying this, why I'm doing this, because just telling people, just say, take this medicine, is not really helping them because you're asking them to spend money too, and this stuff ain't cheap. Some of these medicines could be extremely expensive, and like it's expensive to be a diabetic. You think about the cost of and some of these insurance companies, they're not even paying for some of this stuff that,
Well,
that
not
you
even
need.
not even so much. The cost of medications and so forth, but also the diet change
Yeah,
that you
I
have to
know.
make.
I know, because it
So
costs
when
so
you
much more.
right when you put the two of them together, but at the same time you have to weigh, okay, what's more important, my health or my pocketbook?
And again, what happened though? You think about it. If you say like you have a urinary tract infection or you have a pneumonia, which you mentioned earlier, typically you're gonna feel like crap. Somebody says take this antibiotic, for 10 days, and you're gonna feel better. You're gonna take that antibiotic in all likelihood because you want to feel better. The problem comes once you get to day 5. Say all of a sudden your symptoms get better by day 5. Will you finish the rest of those 5 days, or will you stop after day 5 because you feel back to normal? That's the mindset that we have to get around, is that piece. Plus the cost of meds, plus the cost of eating healthy. Because if you got to feed a family of 5 and you got $10, you're going to go to McDonald's and get a dollar value meal because and that part I understand as well. So we had to find other ways of addressing the needs of the community, because that all of what you eat impacts these outcomes, and a lot of people really don't get that. And the one thing I want to bring up, I had somebody yesterday, I saw this patient I saw for the first time, and she was so proud of herself because she had changed, her blood pressure was still ridiculous, but she had changed her lifestyle, right? She said, listen, I cut out salt. Now I just use Himalayan salt. I looked at her.
It's still salt.
And she was so proud of herself. And I looked at her. I said, you do realize that that is still salt. She looked at me. She's like, what are you talking about? This is a different color. I said, it doesn't matter. I said, the key word is that 4-letter word at the end of all that. I said,
which is
still
salt.
Yeah, I said the only salt that is truly good is that product, no salt, because it's not sodium chloride, But everything else, I said, the problem is that that's marketing. They got you. I said, but that's why your pressures are still ridiculous, and that impact.
If you're just joining us, we're talking about the impact of stroke on African Americans with cardiologist and market director of community health improvement and engagement with Bon Secours, Dr. Keith Newby. 757-440-2665 or 1-800-940-2240 are the numbers to call to join our conversation. What questions do you have about stroke? Let's talk to Ray in Virginia Beach. Hi, Ray. You're on the air.
Well, you brought up salt there, and that wasn't my question, but there's salt in everything, so it's difficult to find food without salt. But I was wondering, I don't have any of the conditions he's talking about, but is there any time that a person should be taking a low-dose aspirin, maybe if they have conditions or don't have conditions? Do you think that's a good idea?
Well, if you look at the new data, if you look at the new data in the literature, they are avoiding aspirin as a primary preventative tool, and it was never, to be honest with you, if you look at any of the past studies, aspirin was never utilized as a primary prevention tool in the literature because there was no data to support that it actually did anything. And in fact, the older you get, especially when you get into mid-60s, they say that your risk of gastrointestinal bleeding goes up. So the guidelines that are out here now are saying that if you've had an event, you've had a heart attack, you've had a previous stroke, aspirin is beneficial to prevent a second stroke. But as a primary preventative tool, no. The current guidelines are risk factor modification. So in other words, like making sure when you see your doc, have them check your blood pressures. Because a lot of people, I know you mentioned that you didn't have any of those conditions, but you'd be surprised that a lot of people may have conditions they don't even know they have. Now, granted, listen, if you don't have any of these, God bless you. I'm glad to hear that. But sometimes they may be undetected, depending on if somebody's checked the hemoglobin A1C level on you, which is a mark of diabetes. Has that been evaluated and looked at? Your cholesterol levels, what are they? and if they haven't been really evaluated, or your doctor says, well, they're a little high, but they're not that bad, that's kind of one of those, well, you need to run something called a 10-year cardiovascular risk assessment on patients, where you can put all your numbers, like your blood pressures, your cholesterol levels, all in a formula, and it tells you what's your risk over 10 years of a cardiac event, and then whether that you should really be. And that's what we're really using now to assess your relative risk of heart attack. The other comment you mentioned about sodium, it's in all foods, you're right. It's a matter of how much in those foods you're eating, because certain foods are like loaded full of sodium and some are not so much so. So the recommendations are, if you are hypertensive, really, and I know this is going to sound kind of crazy, but they're saying that your total sodium intake per day should not equate to more than 1,500 milligrams, which is not much at all.
Yeah, that's
a teaspoon of salt is 2,300. So you talk about all the foods you eat all day long that intrinsically have a certain amount of sodium in it, and I'm emphasizing that because people will say, "But I never add salt." I said, "Yeah, but you was at McDonald's yesterday. I mean, they add it up there for you already. You don't need to add anything more." Though, and I hate to beat up McDonald's.
Yeah, I know. I was going to say fast food restaurants.
Yeah,
Let's
fast
say that.
food restaurants. We'll say that. And I don't want to beat them up but the bottom line is, most fast food restaurants, what sells in America is sugar, fat, salt. That's what sells. That's what people want. That's what they ask for. So they're just giving them what they ask for. The problem is it's killing our folks at the same time.
Yeah. So if you have a stroke, are you likely to have a second stroke?
Absolutely. Because the first question is, why did you have the first one? And that's where the digging has to occur. A lot of people will say, well, I don't have any of these medical problems. I never had a problem before. And I'll say, yeah, but you're 10 years older than you were 10 years ago. I say, because if you're in your 50s, your 60s, and 70s, your relative risk goes up per decade. So, yeah, you may not have had an issue before, but that doesn't mean you can't develop one. And that's the mindset that's so hard to get people to get around. I got folks that's 75, 80 years old saying, I don't understand why my pressure is high now. I've never had high blood pressure before. I said, yeah, you've never been 80 before either. Keeping it real, I say, I'm trying to get you out of that mindset to think, because when you were 20, is different from when you're 80. Your body has changed.
Yeah.
So things can develop. So you really need to be on top of checking your pressures. If you have a family history of stroke, or if you have a family history really of any cardiovascular problem, family history of stroke, hypertension, diabetes, you need to be mindful of that. And to really say, I need to be more diligent to make sure I'm okay.
So it's not hereditary. I mean, in other words, you can't pass it down from generation to generation, or can you?
It's not so much the stroke. Heart stuff. It depends. And the reason I say that is because if you say, like an example, what in our world we look at a true family history is not Grandpa Joe that had a heart attack when he was 85. I mean, anybody can have a heart attack at 85. What's relevant is, especially in men who are having heart attacks at ages less than 55. Your 50-year-old father had a heart attack. There's a reason that happened. That could be your genetic predisposition.
Gotcha.
But what you'll find more so is that it's the lifestyle of that family that creates the issue. Because like you say, somebody say, like, if you have the mother's obese, the father's obese, in all likelihood, the kid's going to be obese. Why? Not because they'll say, oh, it's just in our genes. No, it's in what you eat and how your lifestyle is. And that's what you're transmitting to your kids is a thought process on how to live. That is the part that's being transmitted. It's not some fat gene people think there's out there. I'm like, because I don't know too many third world fat folks that I've ever seen. You don't see it. Why? Because they truly don't have anything to eat there.
Yeah. 757-440-2665 or 1-800-940-2240. Give us a call. Talk to us about what's on your mind regarding stroke. Dr. Ethelyn Gibson, I believe from Yorktown, joins us.
Yes. Good afternoon.
Hi.
How are you?
Oh, good. How are you?
Great.
Good. What's your question or comment?
Well, actually, my comment is I actually serve as chair of the board for our local Hampton Roads American Heart Association.
Oh, fantastic. Okay.
Excellent.
Yes. Hi, Dr. Newby.
How are you?
I'm great. I
Good.
just wanted to let your listening audience know that, our local American Heart Association is here. And so one of the great things that we actually have on our website for everyone is a very simple tool that is called Life Essential 8. And so that's to help you with management of heart disease. And so it talks about 8 simple things, Barbara.
Mm-hmm.
And it's some of the things that Dr. Newby talked about. Eating better,
Mm-hmm.
being more active, quitting tobacco, getting healthy sleep, which is what he talked about. If we can somehow get in 6 to 8 hours of sleep, managing your weight, controlling your cholesterol, but you got to know what the number is.
Mm-hmm.
And a lot of us in the Black community, because I'm a registered nurse and I'm an African-American woman,
Mm-hmm.
a lot of times we go to the doctor and the doctor will say your number is good, but we never ask, well, what is the number?
Yeah,
Agree.
good point. Mm-hmm.
Exactly. And then the other 2 things are managing your blood sugar, and you don't have diabetes. You don't have to have diabetes to manage your blood sugar. Okay.
Mm-hmm.
Thanksgiving just passed, and many of us, instead of having 1 piece of a pound cake, we had the pound cake, we had the 2-pound pie, and we had the sweet potato pie.
Yep.
Okay.
True.
So we're not laughing at the comment.
Exactly.
We're laughing at the we can all relate.
We can all relate to that because that's what you do.
Right. And then lastly, we talk about managing our blood pressure.
Mm-hmm.
That's the very last thing, because, if you don't manage your blood pressure, you're going to wear out your vessels, and then that makes you more prone to having the heart attack or the stroke.
Yeah.
But we have to know what the numbers are, and I'm sure Dr. Newby knows, and I'm out here as a nurse checking blood pressures. People come up to us and they say, oh, my blood pressure is good, 150 over 90.
Ooh.
Not good.
Ooh. That's not good.
She's telling the truth.
Remind us of first of all, Dr. Gibson. Thanks so much for the call, because that is very true. And the American Heart Association, people can go online to find the website. Just Google it, and there's tons of information on there to help you stay healthy. We so appreciate you calling us, Dr. Gibson. Keith, remind us too. What are the numbers? What is the right number for blood pressure?
Okay, so just so everybody's clear, and this is where everybody gives me the gasp when you hear this, but a normal blood pressure is considered less than, and I want to be clear about that, less than 120 over 80. That's a normal blood pressure.
Okay.
An elevated blood pressure is if your top number is between 120 and 129. That's considered elevated blood pressure. Stage 1 hypertension is if your top number is 130 to 139, or if your bowel number is between 80 and 89, that is stage 1 hypertension. So either one. So you could be 120 over 85, that's stage 1 hypertension. You could be 138 over 70, that's stage 1 hypertension. Stage 2 hypertension is if your top number is greater than 140 and or your bowel number is greater than 90. That's considered stage 2 hypertension. So the higher your course of blood pressures, the higher your risk for complications. But even in stage 1 hypertension, you can have a stroke. When I hear stroke alert at Norfolk General Hospital, and if I'm involved in that case, the standard average blood pressure I see is about 138 to 145. Standard blood pressure number.
Mm-hmm.
A lot of people think, well, I need to, and then I have people like what Dr. Gibson mentioned about pressures of 150. Oh, my pressure's great. It's 150. I'm like, what are you talking about? That's not good. Well, it was 200 last time. I said, well, don't be proud of that. I mean,
keep working on it.
Yeah. But that's our mindset. We've gotten used to saying our pressures should be high. Then if you give people medicine and their pressures come down to 120, I feel like crap. I said, because your pressure's been 180 for the last 20 years. I said, I need you to be patient with this. I said, we'll bring it down slower, but we got to get it down to a more controlled range. We have data that says clearly that when you are when your pressures are elevated, if you're in the 130 and higher range, your risk for heart failure is 50% within 5 years. Your risk of kidney failure is 40%. With sometime within the next 4 to 5 years. I know it's this 40. They call it just quote 40 to 45%. Your risk of heart attack is 25%. Your risk of stroke is 35 to 40%.
Yeah, so it's very serious, folks. We need to pay attention to this. So, Keith, what happens you go to the hospital, they work on you, they give you medications, they start you in physical therapy, but what is the realistic timeline in terms of recovery from a stroke?
That could be indefinite, to be honest with you, because if you really look at it, some people, these are permanent changes that they have. That's why it's so important to get there early. If you look at the issues that you got to run across, if you have, think about what are the things that will happen, cognitive problems, memory loss, trouble speaking, physical problems, weakness, paralysis, difficulty swallowing, the emotional part that comes out of it. People get depressed, and sometimes people get impulsive. Their mental position changes. Some people turn into real jerks after they had strokes. I've seen that happen before too. And and that's like that immediate effect that delves into the long-term effects. And that's the part that I really want to push is that the process of rehabilitation is long and arduous. And it could be slow. And then getting people, because if you're depressed, the likelihood of you wanting to participate in your physical therapy rehab program is going to be less, which means it drags out your ability to get better, which drags into your caregivers who are participating in your health. If it's your wife, if it's your children, whomever, you're putting a great deal of stress on them to make sure they take care of you. That's why it's so important if you could prevent a disease process, don't be selfish in your thought process to say, I'll be fine. Because again, if you're going to be dependent upon somebody to take care of you because you have had this event, that's putting a lot of stress on them. I got people, you'd be surprised. I got folks, they're supposed to take care of me. I'm like, okay, I need you to take a step back. You don't know what we have to deal with in the medical world.
The thing that people need to think about also, is the idea that if your caregiver gets worn out, then what's going to happen to you?
I know. Happens, yeah.
It's not like you got a whole line of people there. You may, but you may not have a whole line of people there available to take care of you.
And I don't know too many people that's in that line, to be honest with you. But when you think about, and think about if you're an older person, and say you're in your late 70s or early 80s or older, and your wife is with you, and it could be either one. I've seen, I got some trifling women patients too. Don't misunderstand. I don't want to leave y'all out.
Thank you.
Not a problem. But either one. If you think about it, when think about being a caregiver at 85 years old. Where you have to drag people out of bed, you have to try to get them to the bathroom, get them back in the bed, and you're 85. What the amount of stress that puts on you as an individual caregiver. These are the things that people don't think about when they're making that choice to not take that medicine or to eat that wrong food or to know your pressures are high or you're diabetic and you're not following anybody's instructions. That may impact your life, which is not going to just impact your life in the end. It's going to impact those around you.
Absolutely. So if you find yourself with high blood pressure, say, and you're having problem with cholesterol, and which do you attack first? Because sometimes it could be so overwhelming, too, that some people say, forget it, I'm not going to do anything.
Well, I tell you, if you really think about it from this position, it's interesting that what affects hypertension can affect diabetes, which can affect your cholesterol. The first thing to me is depending on what number is the most ridiculous. I mean,
Okay.
I hate to say it like that, but
Mm-hmm.
if your pressure is 200 over 110 and you're diabetic, but your blood sugar average is, say, 150, I'm going to attack the hypertension first
Okay.
because I know that's the most risky. If your cholesterol level is freaking 400,
Yeah.
I mean, and your blood sugars are they're high but not big. You attack that which you can make the best impact on first. You want to simultaneously do it if you can. The hardest part, if you wanted to say what's the easiest, well, not the easiest, but the most effective first step would be lifestyle change. And that's the part that's the hardest in the end.
Mm-hmm.
But that affects more things that, you wouldn't be as overwhelmed with. But that's getting people in that mindset. So as an example, say you say, okay, I'm diabetic, I'm hypertensive, but I'm eating fast food every day. I'm going to deli meats, all this other stuff. You're going to impact everything that's wrong with you just by that particular mindset. Changing that first mindset, physical activity, getting out and just walking more, it could be more than adequate. But if you can change the lifestyle first, that's the best thing to do because that will impact multiple things at the same time. But whatever number is the highest to me is what the first thing you should attack, and then from there go, that's what I would suggest.
Mm-hmm. And can you fully recover from a stroke?
You can. A lot of it is based on what we talked about, that timeline.
Mm.
I've seen people fully recover when they've gotten to the hospital early, where they've had full recovery. And sometimes the good Lord blesses people and they get full recovery regardless of what they do. But if you want to ensure your success, recognition, and think about it. If, that FAST kind of acronym, say, look at somebody's face, have them smile. If one side goes up and the other side doesn't, there may be something wrong there, possibly. Especially if before they could do that. If they can't raise an arm or whatever the case may be, you want to look at coordination efforts. Just things that have how they speak. Those things. If you can recognize that quickly, or the patient can recognize that quickly, and if they know their medical history and their family history. Those are things, because I'm telling people all the time, listen, if you got high blood pressure, you're diabetic, you're not taking care of yourself, cholesterol is ridiculous, you smoke it like a chimney. You got to know something could potentially happen, So if you know your history, you understand what Dr. Gibson said earlier about knowing your numbers. What is your cholesterol? What are your numbers? What's your HDL
Speaking
level,
of that, too, Kevin from Norfolk sent us a note wanting to know what are good cholesterol numbers.
Well, again, it goes back to that 10-year risk assessment.
Okay.
I could have a cholesterol of 300, but if I have no other medical problems and my cardiovascular risk assessment is only, say, 5%, they don't really recommend treating the cholesterol per se, not with medications, but lifestyle change. But if you look at kind of standardly, a cholesterol level less than 200, total cholesterol level. LDL, you want to see that less than 100, but if you're diabetic, it needs to be less than 70 for LDL. Your HDL, you want it higher than 40. The higher that number, the safer your risk. But the one thing I do want to make sure people understand, and I've even had to share this with some physicians who will say that if you have a great HDL, that obviates the need to worry about the LDL. That's not.
And the LDL is that's the bad cholesterol.
That's the bad cholesterol.
Right.
LDL is like a vehicle that takes cholesterol to the vessels that create blockages.
Okay.
Look at the HDL as a vehicle that takes cholesterol particles to your liver to get excreted in your GI system.
Okay.
So you want more HDL around because that does put you in a better risk category, but it doesn't obviate that the LDL can still be a problem. Now, if you got an LDL of 30, and your HDL is 100, hey, that's great. That's a different story. But if your LDL is 120 and you have an HDL of 90, that doesn't mean that your risk is low. That means you have a lesser risk than if it was some other number, but you still have risk of having a problem. So you still need to make sure your numbers are where they should be. So understanding your cholesterol levels, understanding your blood sugar levels. What's your hemoglobin A1C level? That's your marker of how controlled your diabetes is. And let me tell everybody, don't think because you start taking your medicine 2 days before you come to the doctor, that's going to obviate these numbers. We can still tell. I wasn't born yesterday. that kind of stuff does not work. I mean, because that's the average sugar over the last couple of months.
Right.
So, that tells us whether or not your numbers are actually well controlled. If you're above 7.0 hemoglobin A1C, your cardiovascular risk is higher. The higher it is above 7, the higher your risk for heart attack and stroke.
So we're here in the holidays. Families are going to be getting together, particularly in the African-American community. Do we need to be having conversations about our health as we're sitting around eating that piece of pie? Because I only got a little sliver of the pecan bourbon, and I only got a little sliver of the pumpkin.
Well, I tell you, this society, we have learned that we share successes and enjoyment with eating,
Yes.
and there's nothing wrong
Yes.
with that. The problem is you got to turn it off. If somebody wants to have a good Christmas, go have that good Christmas. If you want that Thanksgiving, have that good Thanksgiving. But you got to know how to cut it off.
All
some
things
people don't
in
know
moderation.
how to cut it off. Yeah. Well, and even in the moderation thing, the problem is you have to understand that piece. If you're, say as an example, you're dieting and and I know some people look at that as a dirty word, but I'm just going to use it for the purpose of this explanation. Suppose you're dieting and you say, I've cut back all my excess carbohydrates, I cut back all my excess fast foods, whatever, and and I'm prepared that on Christmas I want to eat what I want. Well, then do that. I mean, if that's what you want to do for that day, or maybe even the day after. But the problem is you can't eat bad up to that day, eat worse that day, and then, okay, tomorrow I'm going to cut back, but I ain't going to really eat what I'm supposed to eat anymore. I mean, you have to kind of say, okay, I'm going to, my reward for my good work is I'm going to eat what I want on Christmas Day, or even if it's the day before and the day after, but then shut it off for the rest of the year. I mean, just you could do things periodically, but reward yourself with a treat. Don't make it where you want to have a treat every day.
Every single
day. And then
day.
wondering why, you're not getting any better in what you're trying to do.
Well, some help with getting some healthy foods that you can eat. The St. Paul's Mobile Pantry, which is a collaboration between Queen Street Baptist Church and First Baptist Church, Butte Street, which is your church, Mr. Keith, where you are a deacon. And that is the fourth Tuesday of every month. At 698 St. Paul's Boulevard in the Scope parking lot. And everyone is invited. The food bank is also a part of this, I believe. And you come with your trunk empty. If you need to make room for the products, do so before you pull up in the line. Bring your car in the line. And then when you're called ahead, just come forward and then tell them how many people are in your family so that you can get fresh fruits and veggies. So we thank you for that, sir.
I appreciate that. But that's what we're supposed to do.
Absolutely.
We're supposed to help our community the best way we can. There are a lot of people still struggling out here. The jobs are just not giving them the adequate amount of money they need to live, and they're making poor choices because of it. Yeah. And I want to tell people, don't be ashamed to come for help.
Absolutely.
A lot of people will avoid that because they don't want to be labeled as saying they can't handle their affairs. That's not what this is about. This is about how do we help our community thrive, because when you thrive, we thrive.
Absolutely. And thank you, Keith, for this year, because next month we won't see you because it'll be Christmas and there won't be a fourth Thursday. We won't be here. So we will see you again in 2024.
As always, I look so forward to it. But to everybody out there in the listening audience, thank you very much for tuning in all the time. And you guys have a safe, enjoyable holiday season.
Absolutely. Thank you so much, Dr. Keith Newby. And folks, stroke is serious and it affects the Black community unlike any other. So please share this show with someone you love. Go to anotherviewradio.org and download the podcast. And while you're there, check out other shows you may have missed over the past year or even years before, because we have every show we've done online. And be sure to sign up for our eView newsletter. It's a once-a-week reminder of upcoming shows. Next week on Another View, meet journalist Leonard Colvin. He is a pioneer in the Black press, and you are going to want to hear his story. Our theme music is an original composition created especially for Another View by Jay Sennett. Lisa Godley is our show producer. Jordan Christie is our audio engineer, and Dr. Barry Graham answered our phones. I'm Barbara Hamley. Have a safe and wonderful weekend, and let's get together again next Thursday at noon for Another View.
Support comes from Hampton Roads Community Foundation, carrying out your charitable wishes forever, whether it's helping shelter animals, feeding the homeless, enhancing the arts, or supporting students. Learn more at leaveabequest.org.